Welcome to the Long Story Longer podcast.
I'm Dominic Marano. I prescribe meds.
And I'm Katie Brzozowski, and I provide psychotherapy.
Long Story Longer is a podcast about mental health and navigating medication, therapy, and whatever else we want to talk about.
We will discuss topics from each of our perspectives. We will try to keep it to 15 minutes.
But it will probably be longer. Hello and welcome to the Long Story Longer podcast. My name is Dominic Marano. I am a family and psychiatric mental health nurse practitioner. I own my own psychiatric practice and I have a doctorate in the nursing practice. I've been in healthcare for over 20 years and more recently into mental health.
Hey, I'm Katie Brzozowski and I'm a licensed clinical social worker and I have a doctorate in clinical social work and I own a private practice and I've been in the mental health profession for over 25 years.
So in today's episode, we wanted to talk about two mental health conditions that are often confused. The first one is borderline personality disorder versus bipolar disorder. A lot of times they're interchanged and they're two different diagnoses. There are different ways of treating both of them between therapy and medication.
Yes, and I think if you are on social media at all, you've probably been seeing a lot about borderline personality disorder and bipolar disorder. Bipolar disorder, I feel like people have been talking about that for a long time, like, oh, they're so bipolar if they, somebody's moody or something. So what we're going to do today is we're going to go into detail about both of the diagnoses. We're going to clear up any misunderstanding for anyone.
So this diagnosis is pretty common, and that's by the professionals. So up to 40% of people with borderline personality disorder are misdiagnosed with bipolar disorder.
Yes, and it doesn't help that it's BPD for borderline personality disorder, but that also would work technically for bipolar disorder. Yeah. But it's not. If they say BPD, it's borderline personality.
Yeah, and I think we talked about that before, just looking when somebody comes in as a new client, and even if they're transferred with notes, that just using those abbreviations can be enough to misdiagnose somebody. Let alone in mental health, most things, there are overlap between diagnoses. These have a little bit of overlap, but they have their distinguishing features.
So they get confused all the time, and I think it's because they both involve mood changes, right? And they can be very intense and they are often very also misunderstood, like we mentioned. So, but you can't treat them in the same way because that's where it may or may not be effective. And so it is important to know which one you're dealing with. And they can co-occur too, but we're talking right now, we're going to try to tell you which one is which.
And sometimes even the way in which you find that you've had a misdiagnosis is that your treatments have failed. If you're using therapy for, say, bipolar disorder, you may have some improvements, but really medication is with that. So let's start off with borderline personality disorder. So Katie, if you want to take that, we can start there.
Okay. So I want to start by saying that borderline personality disorder, for its diagnosis and treatment, you want to go to a mental health professional, of course, and you also, if you're getting treated, you want to go to someone who is experienced in treating people with borderline personality disorder, because there are specialized treatments and you do have to be trained and know what you're doing. So I have working knowledge of the treatments, but I don't treat borderline personality disorder in my practice. So I'm not claiming to be an expert on the treatment or the diagnosis. We're just telling you a working knowledge of it. But borderline personality disorder, if you think about it, the way that I have been trained to, conceptualize it, and I think so Marsha Linehan was one of the pioneers in treatment for the field and created dialectical behavioral therapy, DBT, which is the treatment for it. We'll get to that later. So I think it was Marsha that actually said that people with borderline personality disorder are like the third-degree burn victims of the emotional world. They have no emotional skin. So things get to them more deeply and affect them more because they do have a lot of very, very intense emotions, and they have a deep fear of abandonment. And then all of their relationships, or many of their relationships, can really just feel like roller coasters, right? There's not a lot of stability, and they just can't manage their emotions in the way that they would want to have good relationships. And they're afraid of people leaving them, which can often become a self-fulfilling prophecy because people then may leave because of their how they're handling their emotions. So some of the core symptoms of borderline personality disorder, according to the DSM-5: frantic efforts to avoid abandonment, unstable intense relationships, identity disturbance, impulsivity, spending sprees, risky sex, substance use. We'll see that again in a second in Dom's discussion of it, not here in this room. Self-harm or suicidal behavior, major mood reactivity, chronic feelings of emptiness, intense anger, and dissociation, especially under stress. These are the main symptoms of borderline personality disorder. The other way to conceptualize it is that if someone with borderline personality disorder is on an island, right, they will not look like there's anything wrong because it really exists in the context of interpersonal relationships. So once you have put another person on that island, then the symptoms may start to, and this isn't, that's not hard and fast, but that's like kind of a way to think about it.
Yeah, and I think one of the things that we were talking about before in preparing for this was saying that looking at someone's history, looking at how they were as a product of growing up, if they had any trauma, or you mentioned abandonment. Sometimes in the formation of any personality, they're called personality disorders, which is a little harsh nomenclature. Nevertheless, I think the idea is that there's a formative thing that happens there.
It's linked to early trauma or invalidating environments.
Yeah, and again, part of that is if someone's had a relationship in the past, say, for instance, just as an example, if their father left when they were young, whether that be things can manifest differently in male and female potentially, but those sort of relationships, sometimes they can impact other relationships with males, or that feeling abandoned, that feeling of worry that this is going to happen again. It's something that I like to say that the brain processes things, and when it doesn't, it gets stuck on them. So it's cyclic. You go through these same patterns of someone's going to abandon me, someone's going to abandon me, someone's going to abandon me. Well, if the brain doesn't process it to a place where it feels safe, then that's going to be the automatic thought that really happens.
Yeah, that's a great way to put that.
Yeah, and I think that with that, part of what Katie was saying is that bipolar disorder has a lot of overlap with that, particularly with some of the symptoms. So let me get into bipolar disorder. This is actually a mood disorder and can be defined as episodes of depression and either mania or hypomania. Bipolar means, bis two. So there's two extremes that are felt there. Unipolar depression, which is something that we'll get into at another podcast, basically is your standard depression or sadness. So let me break it down there's actually a couple of delineations of bipolar disorder. There's bipolar 1, which consists of having a full manic episode. Mania is described as these intense feelings, these high-level energies. Energy so high that you have a decreased need for sleep. You don't even want to sleep because you have so much energy. This would last about 7 days or so, and there is some overlap within mania, which we'll get into in just a minute, with borderline personality disorder. Also, if there's a hospitalization from the manic episode, behaviors are so erratic, so different, such a shift, and then episodes of depression. I think sometimes bipolar disorder is missed because people don't have that episode of mania, but can happen at any time. Bipolar 2 is hypomania, bipolar 2 is characterized by a less intense experience of bipolar 1 disorder. That is hypomania, which is less severe. So you can have a decreased need for sleeps, behaviors that are just a little less extreme, maybe don't require hospitalization, but are a definite shift from someone's routine energy levels and their behaviors.
Is it true, though, then the major depressive episodes in both bipolar 1 and bipolar 2, that they're the same?
The biggest symptom that people say to me is that I have these highs and lows, and people actually like the highs to some degree. Hypomania can be actually useful to some people because you get a lot done and you have a lot of energy. Sometimes you're a bit scattered, but a lot of people use that because when you are depressed, when you go from a high level of intense energy down to a very low low, people hate the low low.
Yes.
But experiencing that, your brain can't run on high highs or even just those elevated highs for very long. It's exhausting for the brain. The last descriptor of the bipolar umbrella is cyclothymia. That's chronic mild ups and downs, but not like full episodes of either full-on mania or full-on depression. They're characterized by shorter stays. Sometimes within there, people have rapid cycling of mood, and that's why it can be confusing, so confusing with borderline personality disorders. So let's just talk about just some of the symptoms of mania and hypomania. Something that's unique is that there's an inflated self-esteem or grandiosity. That's such a shift from when someone's feeling depressed, but now they're like invincible. They think they're so hot and everyone wants them, and then they're capable of doing anything. Next would be something of pressured speech. They just talk to talk. Just pressured speech just comes out, and it's just forced speech, feeling that you have to talk, you have to say something because there's so much energy inside you. Next is racing thoughts, which can be associated with various mental health diagnoses, but these thoughts are happening very fast. Next is risky or impulsive behavior, which would sound familiar from Katie's discussion earlier. And that's just, beyond the norm of where someone is, where someone's engaging in like either highly risky sexual behaviors that aren't the norm, or they're going on spending sprees and
spending.
Yeah, that's a big one. A lot of people get into problems with that.
Gambling too.
Yeah, that's certainly risky or impulsive. Distractibility, which is again a number of different mental health diagnoses, and increased goal-directed activity. This is something where it's not just like, hey, I'm going to go get my degree.
I'm going to start 3 businesses this week.
Leave the house.
Yeah.
I'm going to invent an invention. I'm going to do so many things at one time that I'm not going to finish any of them. But you really have these goal-directed ideas, because I think the brain, when you're in that elevated period of mania, it needs a purpose. Otherwise, you just end up having energy, and it's like you're going to explode otherwise. So sometimes mania can last for days to weeks, and in between someone may feel totally fine, but there's a huge difference from borderline personality disorder, because in where the emotional intensity is constant.
And it's episodes. For bipolar.
Yeah, and it can be hard to sort out sometimes, particularly because, it's some people's mood cycling can be, as we talked about before, can be pretty fast. So sometimes the easiest way to see is how they respond to medication. If nothing changes, then you're like, oops, well, that can't be that, unless you've gone through all the medications that would treat that. But I think within a bipolar episode, you return to baseline. You return to like a normality, if you will, for most places, out of the mood disturbance.
And we had talked about ADHD in a few episodes ago, and it's interesting because you will find a lot of adults that are getting diagnosed now with ADHD were misdiagnosed with bipolar disorder. And you can tell when you start looking at it, if you're distracted, right? If you're impulsive, if you have impulsive behavior, if you are, pressured speech, like those can be for either, really.
Even anxiety. Think about that. There's so much overlap within mental health diagnoses. Teasing them out. That's why it's so important, like you said, to find someone who is a specialist or an expert in that. Because you could go to like 3 different providers, they could diagnose you with 3 different things, but it's whatever, ends up working in terms of your treatment. Not everyone falls specifically into a diagnosis, but really that would let someone know that it's in line with the diagnosis.
Yes, good assessment is key.
Just any other specific differences that I can think of, much like you mentioned, when someone's on an island and no one's bothering them, they're okay. So, but if there's another person involved, typically manic behavior is going to manifest, and it's going to manifest regardless if someone's there or not. But the interpersonal relationships have something, they usually trigger something. And in bipolar disorder, shifts seem more internal. They also tend to last a bit longer too. Like I said, the mania can go for days, depression can go for days to weeks, to months.
It's episodes. So like you said, go back to baseline in between, but for personality disorder, baseline is borderline for personality disorder.
That's their norm. That's what they're functioning with on a day-to-day basis. I think like one of the things that you see between just the middle, like you have the top, which is the elevated, the heightened high-level energy. Then you go back down to a lot of people will fall from the top and go all the way to the bottom, down to a depressive episode where there's a low energy place, a poor mood. And some people's mania also manifest in aggression. It's not necessarily like this, I am the best or whatever. It's like, I want to fight people. Yeah. And then that comes out, and it's aggression, which goes along with the impulsivity, risky behavior. Fights are obviously dangerous, so it can kind of go with that. And lastly, impulsivity and suicidal behavior can show up in either diagnosis, but in BPD, it seems that it's tied to fear of abandonment and feeling invalidated, whereas in bipolar, it's more common in depressive episodes when people feel really, really low. That's not to say that people who are manic don't have that impulsivity heightened where they could act on something if the thoughts were persistently there and then they go to a high energy state.
The mood swings of you could be from joy to despair in a very short period of time, even hours, but it's usually triggered by some type of interpersonal or relational issue. And so that's what, yes, it's some relational issue.
Yeah, there's an insult that happens. Something happens, a triggering effect. And I like to look at it when I talk to people, I'm like, did this just come out of nowhere versus my partner said something, or sometimes people can get in their thoughts, but it's really usually like, well, nobody likes me. It's really tethered to interacting with other people or another person. So something I think something to talk about is ways in which we can sort out the differences, is dispelling myths about them and showing the differences within there. I think with bipolar, people are often labeled as moody, and it's not just having like a rough day. There are shifts that can be life-threatening or life-altering, and there's also a tie between genetics. I think it's something like if you have a close relative, you are somewhere between 25 to 50% capable of getting that. That's also very similar to schizophrenia too, where there's just genetic components that it just runs in families.
One of the other myths about borderline personality disorder is that they're manipulative, like that's equals manipulation, or that equals a manipulative person. And and that's not true. What looks like manipulation is really just, it's a trauma response, or it's just someone desperately trying to avoid abandonment. So they're basically, they're emotionally dysregulated. That's not a character flaw. That's what's happening with them. And so it's not, the person they are isn't manipulative. They are going through something, and luckily there is treatment for that.
Yeah, and I think that's treatment in general. I think just talking about it, a lot of clinicians, and this is unfortunate, will say you can't treat BPD or even other personality disorders. And there's just plenty of data out there that shows that you can. And then I think you mentioned like the dialectical behavioral therapy. That's something that we can probably go into treatment next. So why don't you talk about, for BPD or borderline personality disorder, how do you treat that necessarily?
So as we mentioned before, medications, and I think we've mentioned this before on other episode also, that when you have a personality disorder, medication is not going to treat that, right? Because it's how your personality is organized. It's not something in your brain. You can treat symptoms. So you can have personality disorder and also have anxiety. Then Dom would take over and help with that. But as far as the just borderline personality disorder, in and of itself, it would be therapy as the main treatment. And dialectical behavioral therapy, DBT, I know that's getting out there as people are starting to recognize that and understand that. And that's really the standard. What you want to do is make sure if you are diagnosed with borderline personality disorder and you're going to a therapist, DBT, you get trained, certified. You have to be, if you're practicing true DBT, you're going to be part of a group of other therapists that are consulting to talk about the cases and to really help provide support for the therapist too. It's very manualized. In order for it to be effective, you have to do it in the right way. So not everybody is DBT certified, right? People will say they're DBT informed. That's good because at least they're using some of the tenets of it, but they might not have a group. They might not have, some of the things that are part of DBT that are very important to it. So you just want to check when you're talking to your professional to make sure. There's also a lot of DBT groups you could go to, and there's tons, if you were just interested in finding out more about the treatment, there's tons of workbooks and like self-help type books, even for children.
Hey, Katie, if I can interject real quick, I'd like to explain DBT and why it's so good for borderline personality disorder. I think a lot of times people who have borderline personality disorder have a whole lot of feelings and really don't know how to express them, how to put into words exactly how they feel, how to allow themselves to feel those feelings. Because it's like a state of chaos, that feeling of abandonment, that worry so much about other interpersonal relationships. I like to look at personality disorders as coping that's just not helping with the situation. So a lot of those behaviors that happen in borderline personality disorder, would you agree that it's like using DBT helps change a maladaptive coping mechanism into one that's probably better. And I know there are some clinicians where DBT is a challenge for them because it requires a lot of patience from the provider.
It does.
Are there any other therapies? I know that DBT is the gold standard, as you mentioned.
I believe. I don't want the chemotherapy people coming at me.
Okay, let's just take this right here. What we say are just our own professional opinions. We are not recommending you go out and get DBT, any anti-manic or bipolar treatment. This is us. This is us. We should probably disclose it at the beginning, but we'll do that in the not the credits, the show notes. But anyway, so are there any other therapies that you know of to address BPD?
Well, they use chemotherapy, mentalization-based therapy, and so basically, these are all kind of getting back to what are the themes that have happened in your life? How do you like view the world, and trying to get you to basically change that view a little bit and like kind of rewrite it a little bit.
Taking the coping that you have, putting it through a different lens, or reorganizing it to a place that's a little more useful in interpersonal relationships, it sounds like.
I have a good example. Do you want to hear a good example?
Go for it.
Okay. So I have an example of just something from childhood that it affects you so much later, but it affects you because it changed your worldview and you don't even realize it. So when I was in third grade, I was invited to a sleepover party, and her name was, I'm going to just say, her initials are S.A. because in case she's listening, I don't know. I can't tell. I haven't seen her in 45 years. The day before the sleepover, she called me and she said, the sleepover has been canceled because my father had a heart attack and he's in the hospital. So I said, okay. So the next day, the day of the sleepover, I called my best friend at the time. Her initials are HB in case she's listening. And her mom said she's not here. She's at a sleepover. And I said, who's sleepover? And she said, SA's. So this chick decided that she didn't want me there and uninvited me by telling me that her father had a heart attack. So this created this probably among other things, but it created this idea in my head that people don't want to hang out with me. And so it took many years and, therapy and different things to really like rewrite that and to look at all the times I was invited, because what happened was I started just thinking, just about that. And then I just forgot all the other times that I was invited to stuff and that I was included. So in treatment, you would minimize that and make that more like less of the guiding principle in your head that I am not invited to stuff.
Yeah, and I look at those, I look at the development of how somebody got somewhere. Like, that was traumatic for you. But that's your brain's way of saying, I don't want to be in that situation again. That was dangerous for me, or a perceived threat, or it didn't leave me feeling well. So that's why people, like I said, if the brain doesn't process something, it gets stuck on it. So even that, something so simple as, feeling abandoned by a friend. On your end, your experience of that, it was not nice. It didn't leave you feeling good. So your brain has to protect you. It wants you to feel good for the most part, and it wants you to be productive, move on, do good things in life. So it's going to say avoid situations like that. And then it's almost like an inception thing where it starts off as a little idea and just spreads into a whole lot of other different things. So, and again, different therapies work for different people. Like you said, the biggest part is making sure that you have someone who knows how to do it and to diagnose properly. And again, sometimes it may take some time. Personality disorders, I think, are a challenge because they're not, again, like most mental health diagnoses, they're not all cookie cutter. Not everyone has the same symptom presentation. So, and then some people, again, particularly with BPD, don't exactly know how to express how they're feeling. At least from my experience, you hear a lot of like blaming, but not acknowledgement of how something made somebody feel. Well, this person didn't show up. This person didn't do that. This person did that. It comes out in different ways. You have to sift through it to figure out where it's coming from.
And I do want to say that part of the treatment is making sure that the client understands that, yes, they didn't create this, but they still have ownership over their behavior and how they do things now, and they can change it. They have to be interested in doing that in treatment.
Yeah, I think that, and sometimes I think we talk about this a lot, you and I, just the secondary gain that people have. People don't do things unless there's some benefit out of it, whether that be attention, and they like the attention, because attention is the opposite of abandonment, really, or whatever that may be. If you're not doing something, not being productive, and now you have an excuse, there has to be some gain to it. People hold on to these maladaptive coping things because there's either a perceived protection or there's a gain from it. Well, I think you did a great explanation of explaining BPD, but let's move on to bipolar disorder so we can look at the treatments for that and then, differentiate, see if we can make some sense out of that. For bipolar treatment, usually it starts with medication. Some of the things are pretty obvious when you see someone who's hospitalized. Mania episodes, I think, are so exciting. People have a ton of energy, and it's disproportionate to the situation. Like,
Yeah.
if someone's coming into me for an appointment, they are too excited to see me because this is a psychiatric medication appointment, then I'm like, hey, are you feeling like you have a whole lot of energy? I always ask people, do you feel like you have so much energy you don't need to sleep? Sleep is important. We absolutely need sleep. So what do we do for that? So there are mood stabilizers. There are a couple mood stabilizers that are more anti-manic, meaning they help bring you down from the high. And then there are some that are more on the end that address the depressive side of it. They put a net out so you don't fall so hard. So you may fall from the manic episodes if you're having them, but it catches you in a place. And also, I do think that the mood stabilizers that are less anti-manic do help regulate mood. So some mood stabilizers include things like traditional ones, lithium, particularly for people who have suicidal ideation, lamotrigine, which is one of the medications that I like because it doesn't require blood draws. Lithium does. Depakote or valproic acid does. There's Tegretol or oxcarbazepine. A number of different of these are like anticonvulsant medications that are routinely used within there. But basically, we look at mood stabilizers, again, a number of them. And then there's atypical antipsychotics. Some of those are good in conjunction with mood stabilizers. Some of them serve as anti-manic medications. For instance, there's quetiapine, which some people use for sleep. Some people use as an anti-manic, and other people use as help for mood stabilization. Olanzapine's another one. Atypical antipsychotics, even with some of the mood stabilizers, the biggest complaint about most of them is weight gain and sedation. So people who are on olanzapine, it makes you very sleepy. Seroquel or quetiapine, it can make you very sleepy. We'd like to use that sometimes, particularly for people who are manic, but sometimes it requires an increase in dosing and then down. And, I find that a lot of people don't like to get blood draws, but if you have to, the people who I have on lithium, they need it. They take it. It works really, really well. So treatment, mood stabilizers, atypical antipsychotics. Some people who are on mood stabilizers are also candidates for antidepressants, SSRIs or SNRIs, or atypical antidepressants. But the idea is that you have to be on a mood stabilizer. And the reason being is that some antidepressants will put people into mania. Some of the more energizing ones, like fluoxetine, or they just have a history of putting people into mania. And that's sometimes how people are diagnosed with bipolar disorder. They come in and they're being treated for their depression. And then all of a sudden they're like, hey, I was up for 7 days. I took that. I can't take that again. And the problem with the fluoxetine is it has a really long half-life. That's why. Clear that very long, so you have to ask a really good history, and sometimes it's just people, it happens to people. So but yeah, part of that just leads us into a place of the diagnosis for both BPD and bipolar disorder. The mental health professionals need to diagnose this. So I think it's part of sorting it out using our expertise and experience, and then looking at the failures of medication, at least in my realm, and then maybe for you, if someone's done a certain therapy and it doesn't get them anywhere, maybe that can be key in identifying that they may be a candidate for DBT, which may be more useful for them.
Yes, because if you do diagnose this incorrectly, then whatever treatment, because the treatments are different, if you give the wrong treatment to the wrong diagnosis, then you're not going to have good effects. And then you want to make sure that your treatment is effective. So that's why getting the diagnosis correct is so important.
Don't you remember when borderline personality disorder was popularized in the mainstream media, and everybody thought they had it?
Mm-hmm.
So I think that it was one of those. Some people will will themselves into diagnosis. You read I have all of those symptoms. They are all me, and then it just doesn't add up or gel. And part of what it is I think that humans in general just want a causality for the way that they feel. So if certain things may make sense in that, then they're like, oh yeah, I definitely have that. You definitely need to treat me with that. Mm-hmm. So I think that we work together to sort that out.
It's once you have a diagnosis or an answer, then people feel okay, now I can explain it and now I can move forward and maybe get treatment. So I think that is also a reason why people do cling to some diagnoses, especially when they see them, for the first time online or something. They're like, oh my God, that's totally me. Maybe there's hope. Exactly like what you said. But it may not be them. And you have to, I think with any of the things we talk about as far as diagnoses, anything from the DSM, you have to realize that they are usually pervasive, or they are impacting your life in some way. Like that's kind of how we look at, at how is your functioning? It's really how it impacts you. And these are usually more severe.
The difference between bipolar 1 and bipolar 2, it's pretty significant. But there are people with bipolar 1 diagnoses that can act like they are hypomanic and then it just builds up into a full-on mania, or that they have such extremes between their highs and their lows that it's just about their response to treatment, acknowledgement that there are different ways in which to handle that. I think, as we said before, that in both of these diagnoses, that medication is helpful for bipolar disorder, but there's also a therapy component of that, of like being aware of your symptoms, being aware of those things are coming on. There are people who hold their medications.
Oh, right.
I've seen it a million times where people were like, they're like, I'm manic. I'm like, well, are you taking your medicine? No. Well, why? Oh, well, because my family was coming over. I had to clean. I didn't want to be sleepy. And now they're like fist fighting their family. So that can happen. So it's a gamble. So I think the idea is finding your diagnosis. Mood stabilizers are not going to help people with BPD. So,
Correct.
I mean, making sure that once that's established, sometimes people are just refractory to all medication. It's rare, but it happens. Usually you see some sort of improvement. But if you see no change with that, it's time to consider, was this a misdiagnosis? And then go on with that. And again, I think just hitting home again what I said about the blood draws, why that was so important. People are not going to take a medication with a side effect or a regimen that they don't like. Like if you have to go in monthly or every 6 weeks when you're titrating medication or adjusting medication to get that, and they're like, I'm not sold on it.
Then you're not going to prescribe it, right?
No. And I mean, part of what I will say is this would be the most beneficial medication for you. And I think, like I said, I do psychotropic genetic testing, which also includes mood stabilizers. And if there's an issue with that, I can press with that. Not everybody gets it, there's side effects from medications that people can't necessarily they can't necessarily avoid. For instance, with a lot of the bipolar medications, the more extreme ones, there's a lot of birth defects that can happen from them. So we have to consider, is this worth it to do it? Because if you go untreated while you're pregnant, that's not necessarily a good thing either.
Right.
So you weigh that out between me as the medication provider and an OBGYN, and then see, hey, which would be the best in this situation? There's spinal defects and heart defects for both the valproic acid and then lithium and such. So it's looking at the severity of things. Can things be suboptimally managed while someone's pregnant? It's just a huge thing to consider with the mood stabilizer.
And that actually brings us, I think, to a point we should talk about, that you have to adapt the treatment and not just say, well, this is what the evidence says, we got to do it, because if they're not going to do it, it's not going to work.
Yeah, I will routinely ask people if they're going on a medication that I perceive as difficult, or even if they perceive as difficult, like, are you going to be able to manage this? And sometimes you let people try, and if they can, great. And if they can't, then like, I don't know about you, but in my notes, a lot of times when I'm a little suspicious about things, I'll be like, if this doesn't work, we're going to try X. So the next time I work ahead, because I want to know, all right, well, if this doesn't work, let's come up with a plan B, because you get a feel of if there's other things to consider, like if someone's getting older and this medication isn't good in the elderly.
Right.
Or if, again, blood draws. A lot of people don't like blood draws. A lot of people don't like sexual side effects. And a lot of people do not like weight gain. So that's like,
They're the big ones.
those are the big ones. And I mean, I don't blame anyone for anything. Like, nobody wants to have that. Is it going to happen to you? Oh, there's another thing where one of the side effects is you can have a low white blood cell count for some of the medication. So I routinely draw labs on everyone just because that's my mantra, baseline labs at least. And then if they're on a medication that will impact certain things, then that's when we consider how frequently we may need to get them by the standard versus what's feasible. I think that putting all those things into perspective, making the most out of what you can, it might not be the best treatment, but it's what you have to do. It's the best treatment for your client, not necessarily the best treatment that's out there.
Right, exactly. Great.
So, in summary, BPD and bipolar disorder sound very similar, but they are very different disorders with very different treatments, and worth understanding the difference for both a medication provider and a psychotherapy provider.
Yes, and if you're listening and if you're seeing yourself maybe in any of these descriptions, you are not your diagnosis. These are patterns. They're not life sentences. Treatment helps. You can totally heal and get the right treatment and have, live very This word.
A Wonderful Long Life.
Like wonderful long life. Thank you.
Yeah, and more importantly, like this stuff is confusing to us at times.
Yes, yes.
Let alone just someone who has a little bit of experience with it, and even someone who's going through it. Your diagnosis doesn't define you, but you may have some symptoms that don't necessarily fit into a cookie cutter mold. So with the overlap of BPD and bipolar disorder, it can be confusing, but part of it is have a little patience with it, work with someone who's a good fit, and see what's best for you. I say mental health treatment with medication and even with therapy is a slow process. Things generally don't happen overnight.
For sure.
And then even when they do happen overnight, well, now all of a sudden you are pregnant, or you develop an allergy to a medication, or you have an adverse reaction with one of your other medications. So it's on a continuum with a lot of different factors. So hopefully it gives everyone a little bit of perspective.
So that's all we have to talk about today for this topic. And this is Katie.
And this is Dominic with Long Story Longer. So hopefully you can figure out the difference between BPD and bipolar disorder by now. If you can't, don't worry. There's still other people who are confused.
Yes. And people that can help you.
Definitely.
Bye.